Hello and welcome to part 3 in the series about sepsis. I am Ganesan Abu and I have no conflict of interest to declare. In terms of mortality reduction, early antibiotics accounts for about 50%, whilst source control for another 12%. The effect of early goal-directed therapy was estimated to be about 16%. Early goal-directed therapy is based on a 2001 study by Emmanuel Rivers. It involves a protocol-based approach to optimize tissue oxygen delivery. An intervention is applied to optimize an outcome. For example, IV fluids to optimize CBP, vasopressors for mean arterial pressure, and blood for hematocrit. This approach provided a mortality benefit and reduced length of hospital stay. However, there are concerns about this approach. Firstly, it was a single-center proof of concept study that has not been externally validated. It requires complex delivery and utilizes much resources. There are more invasive interventions, and there was greater use of blood products. So, is there a way of achieving better or the same results with less? 3 trials address this question. Each used usual care and compared this with early goal-directed therapy. By usual care, we mean that if the oxygen saturation was low, then oxygen was given. A low blood pressure was addressed with fluids and vasopressors. The first of these was the PROCESS trial, and this trial was criticized for being an academic hospital study. The ARISE trial looked at academic and non-academic centers, but was also criticized because of including patients who were not as sick as the original Rivers trial. The most recent PROMISE trial included just as sick patients and looked at cost effectiveness and quality of life outcomes. In summary, all 3 trials had equivalent results with fewer interventions and resource requirements. The key message, if we look at this slide, is that the important thing is the time to antibiotics was shorter and less fluid was administered in all 3 of these trials. So now what? What do we do? Use early goal-directed therapy or some measure of usual care? Well, one approach would be to consider the factors causing hemodynamic decompensation in sepsis and address those. Firstly, there is hypovolemia. And the priority in addressing hypovolemia is to restore fluid volume whilst avoiding tissue edema. Secondly, vasodilation of both the arteries and veins lead to a reduction of systemic vascular resistance, causing a drop in blood pressure. Our goal in managing this aspect would be a mean arterial pressure of greater than or equal to 65 millimeters of mercury. Lastly, the heart is not immune to the effects of sepsis, and myocardial dysfunction is also present. The goal in this regard would be to improve stroke volume. We could also use the following mnemonic to summarize this: contractility, rate, rhythm, afterload, and preload. We use fluids to address preload, vasopressor drugs for afterload, and inotropic drugs for contractility. The 2016 iteration of the Surviving Sepsis Guidelines state that treatment and resuscitation should begin immediately, and at least 30 milliliters per kilogram of crystalloids be given in the first 3 hours, and additional fluids based on hemodynamic response. It is unfortunate that a strong recommendation is made on low quality of evidence. Let's look at fluid resuscitation. One has to consider 3 things. Why do we need fluids? What fluids? And how much? Allied to the question of how much is at what point do we cut back or stop giving fluids? So why do we need fluids? Well, sepsis affects the endothelium of blood vessels. Because endothelium is found in all organ systems, the effect of sepsis is widespread. The gap junctions between endothelial cells widen, causing leakage of fluid to the interstitial space. This causes tissue edema whilst lowering intravascular volume. In considering available fluid types, we have 3 categories. Crystalloids such as dextrose, abnormal saline and Ringer's lactate, colloids such as hydroxyethyl starch and albumin, and packed red blood cells. Let's look at what happens after 1 liter of D5W redistributes through all the fluid compartments in 20 to 30 minutes following administration. You'll notice that most goes intracellular and only about 80 mL remains intravascular. 1 liter of abnormal saline or Ringer's lactate results in most of the fluid going interstitial and about 250 mL doing the job. Slightly better with albumin, 400 mL remains intravascular. Blood is best because all of it stays intravascular. So why not give all these patients blood? Well, blood is a scarce resource and comes with its own shortcomings, such as fever, transfusion reactions, infection, and transfusion-related acute lung injury. The appeal of colloids was that the larger macromolecules could not leak through and therefore kept fluids intravascular. There was also a perception that about 4 liters of crystalloid was equivalent to 1 liter of colloid. More recent studies show that 1.3 liters of crystalloid is equivalent to 1 liter of colloid, and the added effect of colloids is only transient and does not translate to better outcomes. In summary, colloids offer no mortality benefit, causes greater renal impairment and coagulopathy, and it costs more. The SAFE trial showed no difference in mortality between albumin and normal saline. Subgroup analysis demonstrated a trend towards less mortality in the albumin group. The Albios trial was done to investigate this finding. And this 2014 trial showed that whilst serum albumin and blood pressure increased, there was no difference in mortality at 28 and 90 days. Proof that one cannot trust subgroup analysis. So the recommendation is for us not to use albumin for initial fluid resuscitation. If the fluid requirements in terms of crystalloids are excessive, then one could consider using albumin. And this would be especially so in the case of sepsis related to abdominal compartment syndrome. So it appears that we are left with crystalloids. And it begs the question then, are all crystalloids equivalent? Normal saline has been the go-to drug largely because of cost. However, the current cost difference is negligible. And saline is really abnormal saline, as it differs more widely from plasma than Ringer's lactate. Normal saline also causes a non-anion gap hyperchloremic metabolic acidosis. And in small head-to-head studies, there was a trend towards greater renal injury with normal saline. In most situations, balanced crystalloids, such as Ringer's lactate, would be preferable, but cannot be used together with blood transfusions because the calcium will chelate blood. So how much fluid does a patient with sepsis need? In the early 1800s, British travelers returning from India were ravaged by a cholera epidemic. The treatment of the day was bloodletting, as people believed that once used to ward off infection, it became useless and had to be removed. In 1832, the Scottish physician Thomas Latter came up with the revolutionary idea of balancing the current between arteries and veins. And to the horror of his colleagues, he violated the sanctity of the human body by cannulating the basilic vein and injecting a dilute solution of sodium chloride and bicarbonate. 1/8 of his patients survived. He used ounce by ounce of fluid to achieve his effect. Whilst today we administer fluids liter by liter. Now, there is some good evidence that too much fluid is bad. For example, in ARDS, when the extravascular lung water exceeds 21 mLs per kilogram, mortality increased by 30%. In the management of patients with acute kidney injury, those patients that had a positive fluid balance had worse outcomes. In the general surgery population, especially after abdominal surgery, a positive fluid balance was associated with reduced survival. So, if a liberal fluid strategy is bad, then is a conservative strategy better? In this study, 48 pigs were randomized to 3 groups of 16. The 3 groups consisted of a control group and a group that was injected with endotoxin and a group that was given a fecal peritonitis. Each of these groups were further subdivided to receive either a conservative strategy of 10 mLs per kilogram per hour of Ringer's lactate, or a more liberal strategy using 20 mLs per kilogram per hour of Ringer's lactate. In each of the 3 groups, the conservative strategy led to better outcomes. Now, the criticism is that a man may be a pig, but pigs, after all, are not human. So, in this human study that was done by Catherine Maitland in sub-Saharan Africa, She did a multi-center randomized controlled trial and had three groups, and a group that received albumin bolus, another that received a saline bolus, and a third group that required no bolus. And each of these groups received maintenance fluids of 2.5 to 4 mLs per kilogram. And she looked at the mortality at 48 hours and at 4 weeks. And I'm sure you guessed as to which group fared the best. Yes, strangely, the group that had no bolus fared the best, both at 48 hours and at 4 weeks. Now, the critical care world really does not know what to do about the study because it was a well-designed, randomized controlled trial, but probably can never be replicated in North America because who would consider not giving a patient in sepsis or septic shock a bolus? The criticism, of course, was that it was performed in children and it was done in Africa. This small Belgian study of 173 ICU patients demonstrated that a positive fluid balance, as shown in the upper blue line, leads to greater mortality. So there's some evidence in sepsis in adult European patients that a conservative strategy for fluids may be beneficial. So what's the science behind this fluid thing? Well, one has to look at the glycocalyx. And the glycocalyx is a glycoprotein found on the extraluminal surface of the endothelium. One could think of it as a gatekeeper. It maintains the integrity of the capillary by preventing shear stress. In sepsis, the glycocalyx is disrupted by tumor necrosis factor alpha. On a side note, in diabetes, hyperglycemia can cause disruption of the glycocalyx, causing microalbuminuria. And similarly, endotoxemia disrupts the pulmonary glycocalyx to cause acute lung injury. So how does this work with excessive fluids? Well, excess fluids stretch the right atrium and causes a greater release of atrial natriuretic peptide, and this denudes the glycocalyx. The net effect of disrupting the glycocalyx is that the gap junctions become wider and fluid leaks out of the capillaries. So when do we know how to stop fluids? The simple answer is that we stop fluids when the patient is no longer preload responsive. So by that we mean when more fluid does not cause a commensurate increase in stroke volume. So how do we measure fluid responsiveness? Let's look at CVP monitoring. The CVP is determined from a catheter that is placed in the superior vena cava, and this is an estimate of right ventricular end diastolic pressure, which is an estimate of pulmonary artery pressure, which is an estimate of pulmonary capillary wedge pressure. You get the idea. It's too far removed from the left ventricular end diastolic volume and stroke volume. Secondly, if we look at the original trials that on which central venous pressure is based, you'll see how widespread the results are. For any value of CVP, the fluid status can either be a negative or a positive, and any level of that. So it's very unreliable. The normal central venous pressure is up to 4 centimeters of water pressure. And if we use this as a guide to treatment, we actually end up with worse outcomes. This graph reveals that aiming for CVPs of greater than 12, even 8 to 12, will lead to worse outcomes than if we aim for CVP at a lower level. So how about using an ultrasound to measure intravascular uh, volume? By this we mean to use a long axis view of the inferior vena cava to assess fluid status and response to giving intravenous fluids. Well, this has also been shown to be not reliable and really is only a similar marker to central venous pressure. How about echocardiography? Well, an echocardiogram may be more helpful because we can directly visualize the stroke volume response to IV fluids. However, echocardiogram is not available widely and you need skill and expertise to utilize this. A simpler test is what we call the passive leg raising test. And in this test, we mobilize approximately 300 mLs of fluid from the lower extremities, and this transiently increases venous return and acts as an autobolus. Now, passive leg raising is well validated, and importantly, it can be used in patients who are breathing spontaneously and even in patients who have a dysrhythmia. To perform a passive leg raise, the patient is placed in a semi-recumbent position at 45 degrees, and then the head of the bed is lowered such that the patient's legs are then elevated to 45 degrees from the horizontal. And the stroke volume or any other parameter can be evaluated after 30 to 60 seconds. So the idea is if the stroke volume increases with passive leg raising, then we can assume that if we give another 300 mLs of fluid, then it will contribute to increase in stroke volume rather than contributing to a worsening of tissue edema. Well, how do we measure preload responsiveness though? And the response to passive leg raising. So we could look at improvement in clinical outcomes, such as improvement in the level of consciousness, a reduction in heart rate, a reduction in the pulse pressure, an increase in blood pressure, an increase in urine output. However, these are unreliable. We can also look at pulse pressure variation on the oxygen saturation monitor, and we can look at stroke volume variation on the arterial line if we had an arterial cannula in place. And this is based on the difference in the pulse pressure readings during inspiration and expiration, and is best done in ventilated patients. The modern way of achieving this is to use a non-invasive cardiac output monitor. And this non-invasive means we can record the improvement in cardiac output 30 to 60 seconds after we perform passive leg raising. And is probably the easiest way to achieve this. And I am told that the device costs about $10,000 and the sensor probes about $110. So still, if one looks at the total cost-benefit ratio, You avoid the skills that are required to put in central lines, and also the possible harm that can come from introducing such devices. In summary, then, about fluids, we can ask, do we need fluids in sepsis? And the answer is yes. How much fluid? There's a suggestion that we use 30 mLs per kilogram within the first 3 hours, but we should use the idea that we need to give this ounce by ounce by ounce rather than liter by liter. And when do we stop? Well, when more fluid will not increase the stroke volume. That means when the patient is no longer preload responsive. In terms of hemodynamic decompensation in sepsis, the second thing to look at is vasodilation and the distributive shock nature of sepsis, and why we choose the mean arterial pressure of 65 or above as the goal. This slide clearly demonstrates that organ perfusion is impaired if the mean arterial pressure is below 65 millimeters of mercury. We also note that the absolute value for mean arterial pressure is important, as one can see that mortality increases dramatically with lower mean arterial pressures. The kidneys are most sensitive to hypoperfusion, and for any given mean arterial pressure below 65, the amount of time spent below this level increases the chance of an acute kidney injury. When considering vasopressor drugs, the thing to remember is don't be a dope. The drugs we consider are dopamine, norepinephrine, epinephrine, and vasopressin. Norepinephrine is clearly the best option as a vasopressor drug because it directly addresses vasodilation. Furthermore, it raises blood pressure without increasing heart rate or inotropy, thereby avoiding cardiac ischemia in an already compromised heart. Dopamine, on the other hand, increases blood pressure by increasing heart rate and inotropy. The risk of tachycardia and arrhythmias are greater. It may have some value in instances where there is bradycardia. Low-dose dopamine for renal protection has been debunked by strong evidence and should not be used for this purpose. Apart from these physiologic considerations, head-to-head trials favor norepinephrine over dopamine in sepsis and in other shock states. Epinephrine exerts its effect primarily by its increase in heart rate and contractility. It reduces splanchnic circulation and increases serum lactate by its beta-2 effect on skeletal muscles. Therefore, lactate clearance as a measure of clinical improvement is negated. If the mean arterial pressure is still below 65, despite adequate fluids and maximum dose norepinephrine, then one should consider adding epinephrine or vasopressin to reach the goal mean arterial pressure of 65. Vasopressin levels are initially increased in sepsis and then reverts to normal. In the context of hypotension, one would expect increased vasopressin levels. Therefore, sepsis has a relative vasopressin deficiency. In the VAST trial, there was no benefit to adding vasopressin to norepinephrine, but a subgroup analysis showed that there was benefit in terms of using the combination to reduce norepinephrine dose. Therefore, I see this as the main use for vasopressin. In the VANISH trial, we learned that adding hydrocortisone to vasopressin results in less need for acute dialysis. Therefore, starting vasopressin would be a trigger for starting hydrocortisone, as hydrocortisone makes the alpha receptors more sensitive to the vasopressor effect. Now, it is desirable to reduce the vasopressor dose to prevent complications such as digital gangrene and compromise splanchnic circulation. Initial vasopressors may be given through a peripheral IV, but if we anticipate prolonged vasopressor use, then central access will be required. So let's try to put this all together and see how fluids and vasopressors work together. So in a patient with septic shock with inadequate mean arterial pressure, the first task would be to start fluid resuscitation. And if the blood pressure is not responsive, then we should consider starting vasopressors immediately. In those patients that are fluid responsive and we have a mild shock state, then we should consider adding vasopressors if volume resuscitation alone is inadequate to maintain a mean arterial pressure of 65 or better. However, in severe shock states, one may consider starting vasopressors up front and then slowly weaning off these drugs if we're able to maintain the mean arterial pressure above 65. The third aspect of hemodynamic decompensation relates to myocardial dysfunction. The heart is exquisitely sensitive to increases in microvascular permeability and interstitial edema. Whereas some organs can cope with a profound increase in interstitial fluid volume, heart function is significantly compromised with only a few percent increase in interstitial fluid volume. There are no studies to prove mortality benefit from using inotropic drugs. However, if organ perfusion is still impaired after adequate fluid resuscitation and vasopressor use, it makes physiologic sense to try and improve contractility with inotropic drugs. At this stage, however, one should seriously consider getting help from a critical care specialist. We will just briefly discuss the few drugs that are used to improve cardiac contractility. The first of which is dobutamine, which has a principal effect on myocardial contractility that translates only to a modest increase in cardiac output. And this drug is usually used in combination with vasopressors because it causes vasodilation and lowers the blood pressure. Phosphodiesterase inhibitors such as amrinone and milrinone also act as inotropic drugs, and we will not discuss these any further. To summarize the hemodynamic interventions, we can go back to our mnemonic. So for preload, we use fluids, for afterload, vasopressors, and for contractility, inotropes. To what endpoint do we resuscitate? The Surviving Sepsis campaign suggests that we guide resuscitation to normalizing lactate. But let's have a closer look at lactate and its use for this purpose. And I want to acknowledge the work of Paul Marek in this regard and took some of his ideas to explain this. Unfortunately, lactate is often portrayed as the bad guy, and this is based on a number of myths. Myth number one is that there is an oxygen debt in sepsis. In 1994, Michelle Hayes tried to boost oxygen delivery to supranormal levels in critically ill patients and found that they actually did worse. Secondly, when we look at septic tissue, the number of ATP molecules in this tissue were found to be normal. So lactate is unlikely the result of tissue hypoxia in this sense. Myth number two is that lactate in sepsis is the result of anaerobic metabolism. The stress response in sepsis causes an upregulation of beta receptors that increases the glycolytic pathway to produce more pyruvate and hence lactate. So lactate production is really a result of aerobic metabolism. The third myth is that lactate causes acidosis. But if we look at lactate, it is a proton recipient, and therefore, if anything, it should cause an alkalosis. Furthermore, lactate production is somewhat protective, and the increased lactate is produced by skeletal muscle, the liver, and oxygen-rich tissue such as the lungs, and it serves as an important and more efficient biofuel for the heart and kidneys. The last myth is that lactate causes increased mortality, and this graph reveals that to be untrue. Sepsis resuscitation focuses on hemodynamics and tissue oxygen delivery. We can deliver all the oxygen we want, but it would be useless if the mitochondria cannot utilize it. The question is, are we missing something more basic? It's an interesting question that warrants more investigation. Vitamin C deficiency causes edema and bleeding, as is evident in scurvy. Vitamin C is also important for proper endothelial function and the synthesis of catecholamines. Its deficiency results in the failure of the sympathetic nervous system, leading to vasodilation. Thiamine deficiency causes beriberi and Wernicke's encephalopathy. Notice how the pathophysiology and clinical symptoms mirror that of sepsis. Both vitamin C and thiamine are decreased in sepsis. Could this combination be the trigger for that dysregulated host response? This study in 2016 shows the effect of low and high dose vitamin C on SOFA scores. Notice the marked reduction in score with high dose vitamin C. Another 2016 study looked at thiamine in sepsis and found no mortality benefit. However, in considering only those patients with thiamine deficiency, there appeared to be a benefit. This study by Paul Marek is creating all the buzz in the sepsis world. Their small randomized controlled trial had 47 patients in each arm. They used a IV cocktail of vitamin C 1.5 grams Q6 hourly, thiamine 200 milligrams Q12 hourly, and hydrocortisone 50 milligrams Q6 hourly. Hydrocortisone was added for its synergistic effect with vitamin C in protecting the endothelium. They showed a mortality reduction, as well as earlier weaning of vasopressors despite less overall fluids being given, and an improvement in the SOFA scores and procalcitonin levels over time. I hope that this presentation has been useful to you, and thank you.